Okay, well, thank you so much for coming out on a rainy morning to the Center for Global Development. I'm Amanda Glassman. I'm the COO and a senior fellow working on global health. We're really honored to have almost the interagency group that worked on the Ebola response sitting with us here today at CGD. Many great welcome to all of you, and thank you so much for your service. I mean, I think that we all owe you a big one. All of their bios are here, and I'll introduce them, but just make a few introductory remarks. So, we've seen examples of dangerous, rapidly spreading outbreaks over the past couple of years. Ebola, yellow fever, cholera, novel Middle East respiratory syndrome, coronavirus in the Middle East, and Zika. And right now, human cases of a strain of avian flu, H7N9, are beginning to increase. Over 500 human cases have been reported this season in China. There's still limited human-to-human transmission, but that could change. And even within the US, another strain of avian flu has been found in poultry flocks in Georgia, Tennessee, Kentucky, and Alabama. These are headlines from the last 2 months alone. Scary bird flu. Now, there's no cause to panic at the moment. But if these outbreaks escalate, there will certainly be lives lost. And because we're here at the Center for Global Development, we should also note the damage to economies and households that could result as well. Because the biggest driver of economic impact of outbreaks and pandemics is not only death and illness, but risk aversion, because people and markets and trade changes. They change their behavior to reduce the chance of exposure. And mostly due to this kind of risk aversion behavior, experts estimate that the 2003 SARS epidemic cost the global economy between 30 and 40 billion in just 6 months. Ebola cost affected countries very dearly, 12% of GDP lost in 4 months in the most affected countries, according to the World Bank. And in Mexico, H1N1 cut tourism by 1 million, leading to a loss of 3 billion, and their pork trade was decimated. The next severe influenza pandemic could be much worse. Under conservative estimates, our colleagues Larry Summers, who's the chair of our board, and Victoria Fan, a non-resident fellow, estimate that more than 6 trillion could be lost. So this is a really significant economic development issue. It's a social development issue, and it's a global health issue. And I think we'll also hear from our panelists today that it's a security issue. So we've done some work in this area, and we really recognize the progress that has been made so far. The Global Health Security Agenda, there was a $70 million appropriation to state for international emergency response related to global health outbreaks. There was an allocation for the Global Health Security Agenda, although 70% of that is used up. But I still think there's much more to do, both at home and abroad. And last week, Time published a cover article with a dire warning: we're not ready. Science knows how to fight an outbreak, but policy still gets in the way. And that's what we are here. We're the policy wonks. Why are we in the way? So I'll leave it to our panelists to define a lot of challenges and outbreaks, but I'll just mention one before we start, and that's the lack of sustained public interest, and therefore budgets, and therefore effort. I'm changing the slide. Okay. So this is Google searches on outbreak and pandemic. These are billions of interest points, and that big mountain in the middle is Ebola in 2014. This is since 2013. Let's just overlay that with the NFL. We Americans, we love our football. But I think the important thing to notice, on the one hand, interest in outbreaks and pandemics is not very high when there's not one going on. So nobody really cares. But when there is one going on, it's of passionate interest to everybody in the world, and much more than football. So any politician, any appropriator, any policy wonk really needs to pay attention to this threat. So let's move on now to our panelists on that utterly superficial note. This is a very important problem, but I think it points out the difficulty that we have in prioritizing this kind of effort on an ongoing basis. So we've asked each of the panelists to give their initial remarks on how you see the issues and the lessons from your own experience and opportunities and challenges as we look forward towards better pandemic prevention and preparedness. So let me start with Dr. Smith to my right. You're from the Department of Defense. Tell us a little bit about your views on the issues.
All right, well, thank you very much for the opportunity to talk today. We consider this a very important issue and really approach things from an all hazards approach, but this is a critical part of our planning, and one thing the Department of Defense, I think, clearly does well from my perspective is planning. So, but DoD has a long history of involvement in this space. It actually dates back to before the Republic. George Washington, if you're not aware, saw the issues with variola, and the Europeans were already vaccinating, and made a very risky move at that point to actually mandate that the entire force would be vaccinated against smallpox. And then we know Walter Reed, yellow fever, et cetera, and a lot of the vaccines that are on the market today came out of the need for us to protect our force and project it forward. So that's why we are actively involved in this space. But over the last probably 20 years, and clearly with the HIV/AIDS epidemic, I think was the first place where from perhaps a government and also a departmental point of view, we started seeing the destabilizing effect that an emerging infectious disease can potentially have on economies and on the stability of governments. And since then, we've seen SARS, $50 billion loss in Southeast Asia, along with H1N1, MERS-CoV, and then the Ebola crisis, the first time we've ever deployed for an enemy that was an infectious disease. And so clearly, I think the understanding of the connection of this issue, global health in general, with security is well recognized. And as we say, this whole effort is one of the tools in the toolbox of the commander in his national security toolbox, that they clearly need to be involved in this space. And I think there's an understanding across the department. Now, just, and I always take time to sort of educate in these kinds of venues relative to and have a brief discussion about what we are actually doing in this space and what we've been doing differently. And I'm going to break it. We're big supporters of the global health security agenda, and I'll break it up into the three components: the prevent avoidable epidemics, the ability to detect early and to respond rapidly and effectively. And on the prevent side, we've already talked about the fact that we're actively engaged in the vaccine development space. A lot of the vaccines that are on the market came out of our work. Think hepatitis A, yellow fever, Japanese encephalitis, adenovirus, et cetera. And just using Ebola as an example, one of the vaccines that's in clinical trials came out of the work that DoD is doing. We also have a Zika virus in clinical trials, and also our vaccine, and also MERS-CoV. So as part of the prevent, that's important. Also in the detection piece, we have the need to be able to do it in very remote, very difficult situations, which is also in the global health space a common need, and have been doing a lot of work in those developments. And just another example related to Ebola, the majority of the probes that were used to diagnose the disease actually came out of our program, and we were the primary supplier of that capacity, particularly early on, and then it gradually expanded. And then the third component of that, of course, is diagnostics. Is therapeutics. And Ebola, again, the ZMapp came out of the work that DoD had done in collaboration with Canadians. And so clearly we work very actively in that prevent space. Relative to detect, that's another area that I think is critically important to this. And we have a very rich research lab network with 10 labs around the world, strategically placed, where we work collaboratively with the international community, and particularly with our own community, with CDC and other members of the interagency, to have as robust biosurveillance and to be able to detect things early and nip them in the bud when that's actually occurring. And another just plug for DoD, the H1N1 was initially recognized by our laboratory in San Antonio. We were the first ones to characterize that and recognize that that one was occurring, just as an example. And then I fund a program called GEIS, the Global Emerging Infectious Surveillance and Response Network, to the tune of about $60 million a year to help fund the biosurveillance component of that. And just as an example of what comes out of that, a large number of the influenza samples that are used by CDC and the World Health Organization to determine the makeup of that annual flu vaccine that I'm sure you're all subscribing to come out of the work that comes out of that robust surveillance network, but a true national asset, I think, with the labs. Another program in DoD is the Cooperative Biologic Engagement Program that does a lot in building capacity to be able to detect both and surveil in countries around the world. It's primarily oriented to something we call select agents, those especially dangerous ones, but if you are able to work in that space and be able to do that surveillance, then clearly it has applicability to non-select select agents. And then we're also working with the interagency on trying to get better at pandemic forecasting. And then the final area is the response rapidly and effectively. And certainly we're working around the world through the Global Health Security Agenda, primarily with the military partners to try to improve their capacity and capability in that. Obviously, we have stockpiles and our own sort of response and plans relative to any sort of outbreak. And then we work actively in the interagency working on the development of countermeasures. FMC is the organization that sort of gets us all together, funding through BARDA, DoD, and others to be able to work that. And then another product that came out of H1N1 is an increase in our advanced manufacturing capability, both within the DoD, but also nationally, recognizing that we did not have the capacity to produce quickly responses necessarily, and now there are a number of efforts going on to be able to increase that capacity, because there wasn't necessarily the pharmaceutical economics piece to it, but clearly a need from a more strategic economic picture. So that's just a quick sort of somewhat sales pitch, but to tell you that we're actively involved in the space. The DoD clearly sees this as an important national security issue, that it is clearly, being a physician, very interested from a health point of view, but we see that direct correlation and the need for us to be actively supporting the space. I should point out that typically we are supporting others in the space, that we're usually not the one, other than when it's directly with militaries, taking the lead, but we stand as ready as you can be for this kind of event. So thank you for...
Okay, thanks. I've actually learned a lot from that description of things that the Department of Defense does, and particularly on the ability to scale up manufacturing capacity in case of need. So Dr. Martin, tell us from the Centers for Disease Control perspective.
Well, thank you, and thank you to the panelists to be here today. It's a great honor to be with you. I think I'll build off what Amanda, what you and David have said here, and as I'll start out by saying that we know outbreaks can start anywhere, they can be transmitted anywhere and anytime, and we know that disease here can be there tomorrow, but we know there will be the next one. We just don't know where and when, but we do need to make sure that we're ready to respond and to detect those as well. As David mentioned, going from SARS to MERS coronavirus to Ebola to Zika, we see that these keep coming, and we need to be able to make sure that we're prepared. And I say we, I mean countries, and I mean globally, that we have this sort of be able to respond. So I wanted to focus on 4 sort of key issues. The first being starting maybe at the country level and then working up to the global level. So at the country level, all countries must be prepared. I mean, this is a strong lesson over and over we learn from all outbreaks that you showed on the slides, the importance of country preparedness. With the Global Health Security launch in January 2014 in a snowstorm, Amy? Yes, it was, here in Washington. I think we really saw that To date, we have over 55 countries that have joined this. In addition, there's non-governmental organizations, there's the private sector roundtable, so everybody's seeing the value in this. At the US government level, it has really been in all of USG, DOD, CDC, USAID, Department of State, Homeland Security. I mean, all of the groups have really come together to do this, and under CDC under the Health and Human Services responses. So to date, I think we've seen this, the importance of the US government coming together in their efforts for this. And then secondly, what we've been working with countries is what's called the Joint External Evaluation. And this allows countries to have that sort of basic report card of where you are, as David said, prevent, detect, respond. Where are you in your ability? You get a score in these areas. And from that, how can they then close the gaps? And this is becoming a new way, a new standard, because countries are actually putting these on a public website. It's transparent, and it's allowing the government itself to identify domestic resources, but then also how do we get other partners and other bilaterals engaged in this as well. And some of the successes, CDC has been working closely on the ground in the 17 phase 1 countries for the global health security of the US government. And we've seen in, I want to say 8 of the 17 countries that going down to the subnational level, we have 80% of these districts reporting to the national level every month with what diseases they're detecting. We've seen 12 of the 17 establish emergency operations centers so that when something is detected, they can quickly respond within all of government, bringing in animal health, bringing in agriculture, bringing in Ministry of Health and all the needed partners who are engaged in this. With Cameroon, I want to just give the example. They were taking 8 weeks to respond to an outbreak. They are down to now 24 hours when they had a highly pathogenic avian influenza virus detected. So the importance of them being able to quickly get their response together, detected, and being able to then look at what they can do to prevent and respond to these efforts has been really critical in moving forward. CDC has also been working in strengthening the workforce. We've trained over 1,600 what we call frontline health workers. These are people, healthcare workers, professionals at the local level, at the lowest level, who can detect something and will report it up. And just one example, there was a training in Mali, and they went back to their post and said, I think we've got meningitis here. And that was like a week after the training, and sure enough, there was a meningitis outbreak. So the opportunities are just bountiful here in being able to detect more, being able to stop them quicker at the source and prevent these efforts. So after countries needing to be prepared, the second is, as David talked about, is the science and research that needs to go into this, be it the medical countermeasures, the vaccines, the diagnostics, the drugs as well, that we need to make sure that we have these available and that we can use them. There is now the Coalition for Epidemic Preparedness and Innovation, CEPI, which is making an effort starting with vaccines, but really seeing the value of that we need to have these medical countermeasures and do the research. There has been research, as David mentioned, DOD had been doing these things. How do we get those more involved quicker, and how can we respond faster to have those available for use during outbreaks? And I wanted to use the example of the H1N1 during the pandemic in 2010, where we were able to get a vaccine quickly made, but then there was not enough. And so countries kept their supplies for themselves. We were worried about low and middle income countries that didn't have access or didn't have agreements with manufacturers for vaccine. And first, there was very little, sharing. Like maybe we'll give. WHO had negotiated 10% of the global stockpile for these countries. By the time the vaccine was at full supply, was a year after, and you'll remember then it was really not so. Found out to be so. It hadn't spread as much. It hadn't become the next pandemic, and so how did they start to think about what could be done with the vaccine? So the importance of being able to respond quickly when you need it, have the vaccine, and the use of the vaccine is really critical. The third area I want to talk about is community and communications. And this is something you don't develop during a response. You need to do this every day, because in order to be able to have that surge when a response comes, the engagement with community, going back to the pandemic in 2010, with that, when we had vaccine, we prioritized healthcare workers. They have to have the vaccine. Well, vaccine uptake was less than 30% in some countries and down to 6% in some countries. So they really didn't want the vaccine. And so how are you going to have them convey to their patients who are immune compromised or pregnant women that they should be vaccinated if they weren't doing it themselves? Also in the Ebola outbreak, with the burials, we're working with communities. They didn't want to send people who were sick to the facilities because that's where you went to die. So I think this is really important about the working with communities, making sure the how to put it into their terms and cultural issues, and then the risk and crisis communication. There will be very quickly information out there in social media, as we've seen, and if ministers of health or partners stay silent in this space, it just grows, and it's misinformation. So we have to make sure that we're in those spaces where people are looking, as you showed with Google, when we have information that's available on that. And this is where, in the Ebola outbreak, the private sector played a huge role in their workers going back into the communities and talking to their people who lived in the communities about what they could do to protect themselves from Ebola. And this was a huge role that came out of the private sector work. So my fourth area is now going up to the global level. And this is that coordination for surge and emergency coordination at the global level that needs to happen. And with CDC, you may wonder, we are a domestic agency primarily, working 24/7 to protect Americans. But in order to do that, we also have to work globally. In 6 of the 17 countries we've been working with under global health security, these countries have detected new pathogens. And so we have to understand what's the risk, how will it spread, how do we make sure Americans are living here and abroad, how do we make sure that we can protect people where they are. And I just wanted to give a few statistics on the economics. The U.S. globally exports about $300 billion of goods and services to 49 countries who we are concerned about their health security. And within that as well, it employs in the U.S. 1.6 million workers. So there is the connection and the importance, as Amanda said, with the commerce and trade and what we're doing in here, and leads to the point that when there are outbreaks, health security can cause economic destabilization. It can change political environments, and this affects national security. So the importance, as you mentioned, in the 4 months with Ebola, $2.2 billion affected GDP for the 3 countries of Guinea, Sierra Leone, and Liberia. And we have seen, just lastly, I wanted to just mention that we know that no country can do this alone, no organization. We need to figure out how we do that emergency coordination, how we can surge and help countries as they do this. And CDC is part of this community, is part of the US government, and how we do this together. It does cost a lot less to prevent now versus being able to respond later. And just to give my last sort of comment on this, in the 21st century, it was estimated in a recent report about $6 trillion spent in responding to epidemics. That's annualizing to about $60 billion a year. If we put that money towards prevention, it could be $4.5 billion a year, or 65 cents, US cents, per citizen of the world. So just the value of what we can do if we look at the prevent, detect, and respond. Thank you.
Thank you. Okay, so now we're turning to those who are now outside of government. Jeremy Konner Dyke used to be head of the Office of Foreign Disaster Assistance at the U.S. Agency for International Development and led the Ebola response. So, Jeremy, why is the U.S. government so important? Okay, this is a global problem. What's our special role? And then what do you see as key lessons from the Ebola response, and what could we be doing better?
So I'll start with the key lessons, and then I'll get into a bit more on the important role of the U.S. government. But I think first, it's really important to just recognize how at risk we still are here. Ebola, by the standards of infectious disease, was not should not have been a very hard thing to stop. It compared to a lot of other potential pandemic threats, It is not a highly contagious disease. The people who became infected were principally direct caregivers or medical staff who were engaging directly with patients. And so the fact that a disease of that nature gave the world as much trouble as it did is a really sobering, I think, a really sobering statement on the state of global preparedness for a real pandemic. And what a real pandemic could look like, I think you have to look back to the early 20th century when there were several large outbreaks that killed people in the millions globally, and in the case of the Spanish flu outbreak, estimates vary, but as high as 50 to 100 million, with 500 million infected, which was about a quarter, roughly, of the world's population at that time. So if you extrapolate that into today's terms, and think how much more interconnected the world is 100 years on from the Spanish flu outbreak, the risks are really staggering, and I mean, it's almost science fiction territory to think what this would look like. Think of the panic that was created in this country by Ebola with the single-digit number of cases that happened here. And imagine what would happen if something like even something much smaller than a Spanish flu type of scenario were to play out. And you're really talking about a very severe threat, not just to the health of this country, but to the stability of our economy, the stability of our social fabric. It's really extraordinary to contemplate. And so the prevention and the preparedness that David and Rebecca have talked about is really key. I'll talk more about what we've learned on the response side. That's more where my expertise lies. Some really important lessons out of Ebola and areas where we now know we need to do better the next time. The prevention's been covered. One thing I would just add to that is it's really interesting to look at with Ebola, where did it take off and where did it not? So it took off in the 3 weakest countries in West Africa. It did hit several of the neighboring countries. There were cases that came to Senegal. There were cases that came and some modest spread in Mali. And there were cases and modest spread in Nigeria. But all three of those countries were able to contain it with a lot of outside support, but they were able to contain it. And those are not countries with extraordinarily strong health systems by global standards, but they were considerably stronger health systems than those in Sierra Leone, Guinea, and Liberia. So preparedness, even a modest level of baseline preparedness, matters an awful lot. A big takeaway for me on Ebola, as I think about it now from my position outside of government, is just how little preparation, how little planning we had at our fingertips for how to contend with something like this. And I liked Amanda's framing at the beginning from the Time Magazine article that we have the science, we don't necessarily have the policy. And I think that is a gap that continues today. We know a lot about the science of most of these diseases, not as much as we'd like, but we know a lot about the underlying science. And we know with most of the pandemic threats that are out there, the basic configuration of variables that could emerge. What we don't know is how do we trace the lines from the behavior of a particular pathogen when it goes to scale to what are the public policy responses that we need to put in place in order to contain that. What we found on Ebola was we knew the science of how to contain Ebola. We didn't know how to scale those responses when it went from being a small rural outbreak to a massive multi-country, heavily urban outbreak. Mm-hmm. And the tools that you use when it's a small rural outbreak don't scale very easily. Mm-hmm. And so we were faced with a whole range of other challenges that we had no preparedness for. We shouldn't face that again. There is and this is one of the things I'll talk about in a moment, we need much better planning for that. Another big lesson of Ebola is how much difficulty the global public health community and the global emergency response community have talking to each other. We didn't speak the same language. We didn't know each other's systems. We didn't know each other's worlds very well. And so for the first several months, a lot of our time was spent just figuring out how to effectively talk to and engage with each other. And I think we've made a lot of headway on that within the U.S. government. Certainly, we had made a lot of headway on that. And both my old office at USAID And Rebecca's team at at CDC have engaged quite extensively, and I'm sure are continuing to engage quite extensively on getting a better interface in place so that we don't have that spin the next time around. But we need to continue doing that, and we need that at a global level because it was just as big a problem within the UN system between the World Health Organization, which had remarkable scientists but very weak operational capacity, and other UN agencies that had strong operational capacity but didn't really know how to deploy it for a public health crisis. The third thing I'll touch on is financing. We had this I can talk about this now because I'm out of government. It's fun. We had this really strange challenge up at the beginning of Ebola, which was that DoD had a lot of money for this and no one else did. And so at AID, it was nearly the end of our fiscal year. We were virtually out of funds. CDC doesn't have standing large money to do a global health emergency response. But DoD was sitting on about $1 billion of unspent OCO funding that Congress allowed them to reprogram. So we had a jackpot at DoD where we didn't need them. I mean, we needed some money, but we didn't need nearly the volume of money that we had available, and we didn't have the money where we needed it. That was eventually rectified, but not for months and months, not until months and months later when Congress passed a supplemental appropriation as part of the omnibus. And then CDC and AID had the money we needed. But that's, I mean, from a prevention and preparedness point of view, that's totally inexcusable. We need to be able to have the money up front in the hands of the agencies and actors who need it, rather than have to spend months navigating financial limitations that are, that divert effort away from where it should be. And so we were looking at having DoD do things that really AID or CDC should be doing because DoD had the money. That's not a good use of anyone's time. It's not a good bureaucratic exercise, and it's something that I think it's encouraging that in the 2017 appropriation, there is some money. This is money that Amanda referenced. That needs to become much more common practice, and it's critical that, like we have funds for other sorts of emergencies that we can draw on, that there be money for this. And then the last thing, I was going to talk about behavior change, but I think Rebecca's covered that, and I agree with everything she said. I'd only add that's the most rapidly scalable intervention. It's a lot easier to scale behavior change than it is to scale clinical interventions, as we found on Ebola. Last piece is the importance of U.S. global leadership on this. When President Obama went down to the CDC in September of 2014, and 2014, right? Yeah. And talked about this, the world paid attention. And the world paid attention because U.S. credibility on public health matters and on global security matters is a precious global resource. And when the U.S. can speak credibly about these sorts of issues, the rest of the world will pay attention and the rest of the world will take it seriously. And I think we sometimes underappreciate how important that is and what a global public good that is. So a few steps forward coming out of those lessons. We need much better planning for a variety of different disease scenarios. The influenza scares in the mid-2000s sparked a lot of planning around influenza. I don't think that's been too much updated since then. We don't have anywhere near that level of planning on most of the other types of pandemic risks, and we need it. We need a modular approach to policy planning that can look at, depending on the variant, the different configurations of different types of diseases, what sort of policy tools should be deployed and should be used, what's relevant and what's not. We had to figure that out in real time on Ebola, and it was really hard. Having some sort of a guidebook or framework for that would have been very useful. We need to get much smarter on the communication and behavior change toolkit. It's something everybody knows is important. It's a key, huge takeaway out of Ebola. It's also a huge challenge. As we've seen on diseases like HIV/AIDS, changing behaviors, changing cultural behaviors can be very, very difficult, and we need to get much smarter on how to do that. We need resources to the right actors at the right times, and so far I think our political system has struggled to deliver that. And we need the USG whole of government system to work. We need to be able to avoid this kind of spin that we had in the early months of Ebola, where we were trying to figure out who was on first. That needs to be much better defined so that we can just get down to business when a major crisis strikes. And the last point is we need the U.S. government to staff up so that we have those credible voices in place when, not if, but when something hits during this administration. The role that Raj Shah was able to play, the role that Tom Frieden was able to play, having some of these key players in place was really key to getting the U.S. message out there and getting the world to pay attention and get on board with a coordinated response on Ebola. It's encouraging that last night the administration announced they do have a name that they're putting forward for USAID administrator. I don't think there's been anything yet for CDC, and there are a lot of the other key positions that worked on Ebola and that will work on the next outbreak that remain vacant. Those need to be filled. Thanks.
Okay. So long agenda. Now we'll end with Amy Pope, who was director on the National Security Council during the Ebola outbreak. You oversaw the interagency. You dealt with the political and media consequences. Tell us a little bit about what you learned and what you would recommend going forward.
I'm happy to. And thank you, Amanda, to you and to the Center for Global Development, and to my partners for many years in working on these issues. It's a timely conversation. It's a crucial conversation. And I'm so grateful that you've convened us all here today. So as Amanda said, I served on the National Security Council staff. I was President Obama's Deputy Homeland Security Advisor. And that meant that my responsibility was to look around the world to identify, both in the United States and outside our borders, what might be threats to the United States, and then to make sure that we were as prepared as possible to respond to those. And people would often ask me, what keeps you up at night? And I had a long list from which to choose. I was responsible for foreign terrorist fighters returning to the US. I was responsible for migration along our southwest border and on the seas, on refugee resettlement, on earthquakes and hurricanes and anything that would go wrong domestically. And then there was infectious disease. And I will tell you, when I first came onto the job, I was not as focused on the threat that infectious disease posed. But what I learned, and I think we all learned through the course of the administration, that infectious disease was the one thing that we could not get our arms around in advance, and it required a level of flexibility and agility that we did not necessarily have within the United States government. And what I also realized, what we all realized, is that even though my primary responsibility was homeland, what's happening here in the United States, that our borders do not define the impact of any infectious disease or our response to an infectious disease. It sort of goes without saying that a pathogen doesn't need a passport. We would say kinds of things like that all the time, because we had so little ability to control the movement of pathogens across our borders. There's so many things we saw, for example, with MERS. MERS presents like so many other diseases. You can't possibly put up Customs and Border Protection officers at all of our ports of entry to identify people who might be exposed to MERS and might be able to pass it along. We had the same issue with Zika. So our traditional tools for protecting our borders, protecting the homeland, simply wouldn't work. And what we came to, and I kind of call myself an evangelist for the global health security agenda, is that the only way to best protect the United States was to build the capacity of partners around the world to prevent, to detect, and to respond to emerging infectious disease. And that plan was actually the best way to protect the United States. There were, of course, a number of lessons that we learned, and many that have been echoed by my colleagues here. From where I sat within the interagency, at the top of the interagency community, I think my perspective might be slightly different, but many of the themes are similar. And what we learned and we hit a number of diseases over the course of the administration, from H1N1 at the very beginning, SARS and MERS, Ebola, Zika. But there were some common themes that emerged. And one was, first and foremost, you've got to get the interagency players together, and you've got to get them together quickly. The interagency community tends to work in silos. What DoD is doing is not necessarily known to CDC. It's not necessarily known to USAID. It's not necessarily known to our embassies. And that posed significant problems. Jeremy alluded to the fact that we didn't even know how to speak the same language in many cases. And we saw that play out over and over again. It wasn't that we couldn't even speak the same language. Sometimes people had no idea that there was another agency or entity present in some country and could provide some capacity there. So getting the interagency players at a very high level very quickly around the table. And it needs to be broader than what you'd think. It's not just HHS and State Department, CDC, and USAID. You also need to have DOD. You also need to have the Department of Homeland Security. You often need your embassies represented or your State Department heads at leadership. You need to have, in some cases, the Department of Commerce. In some cases, you need to get CBP, the Customs and Border Protection, or TSA. It's a whole range of actors who are not sort of necessarily obvious when you start, and you need to get them around the table. You need to make sure at the beginning that we're all operating from the same facts and that we're sharing capacity, authority, information, and that we're all very focused on the same mission. And that sounds easy, but in reality, that is really, really hard work and takes a lot of commitment to bringing together the community. Second, I can't say enough about the importance to build rapid diagnostic and biosurveillance capability. With Zika, we were really struggling to know where are the outbreaks. Zika is very difficult to detect. A significant number of people who are infected with Zika don't show any symptoms at all. And so building the ability to quickly identify who had been exposed to Zika was critical to understanding what kind of response efforts were needed. And so that research and development, that capability, even if you're starting from very basic sort of tech tools, iPhone app tools, for example, it needs to be prioritized and move forward very quickly. We also, as we've heard a couple of times on the panel, messaging is critical. I can't tell you how much anxiety was created around Ebola because of messaging. We sort of joked at the time in a sort of very grim way, that kind of joking when you're in the middle of a crisis, that it was actually a tweet by Donald Trump that fueled anxiety about Ebola in Dallas. And who would have guessed? We were not prepared for the impact of social media on public anxiety at that time. We should have been. In hindsight, that really impacted our thinking about Zika. But getting a message out there quickly, getting the facts out there quickly, and making sure that there are trusted people identified who are speaking to those facts very early on is incredibly important for the US government, and should be one of the first things that the government decides to do. Obviously, time is of the essence. You don't have the time in the middle of a crisis to figure out who owns what, who's going to speak, whose responsibility is what. And this is why Jeremy's observation that we need to work out these playbooks well in advance is so important. We know that there's going to be another pandemic. We know that there will be emerging infectious diseases. We need to take all the lessons we've learned and to build these playbooks so that we can move as quickly and agilely as possible. And finally, this to me is one of the most important lessons. The funding is key. We did not have funding for Ebola. We did not have funding for Zika. And Zika, it was really puzzling to those on the inside because Zika is clearly a public health threat. The impact on developing fetuses can be significant. It seemed to us this was sort of a no-brainer and nonpartisan. All of us can get together and acknowledge the importance of not having Zika spread in the United States. But the partisan bickering that went on in Congress was astounding. And many in Congress wanted us to take money from our Ebola response to fund the Zika response. And our position internally was, okay, these are both really bad things. And you want us to take our eye off of this threat so we can deal with this threat. It just is a terrible way of doing business. And when you're going to Congress and having to negotiate every single time you have some sort of outbreak, it puts you months behind the curve. And that is not where you want to be if something is spreading quickly. So looking forward, and I think I bring to this a national security lens, not necessarily a public health lens, but my takeaway after my years within the administration is that we need to treat infectious diseases like the threat that they actually are. We learned after 9/11 that our infrastructure to identify and connect the dots between intelligence officers and frontline officers on terrorism, that it was insufficient. We built a whole new agency, the Department of Homeland Security, to put together relevant components so that we could be better prepared. We spent billions of dollars, both in terms of countering terrorism overseas, but also in building our own capacity at our own borders to identify and respond to counter-terrorist or to terrorist threats. We need to take some of those lessons and apply it to infectious disease. There's no question that 9/11 was a horrible tragedy, that it caught us by surprise, that it revealed deadly gaps in the way that we did business. But what Jeremy pointed out is that a pandemic threat could be far more deadly. You know, the Spanish flu killed over 600,000 Americans. You think about that, 600,000 Americans versus how many were killed in terrorist attacks on US soil. And we hope that in 2018, we have far better ability to respond to the next pandemic threat and that we wouldn't see that kind of fatalities. But the truth is the world is far more global. People are moving far faster than they were in 1918. People can get on planes and in a heartbeat, you have a pathogen coming from some remote part of the world into New York City. And so we need to appreciate the threat that that is to the United States, and we need to take action. When you look at what we're spending, we're talking about $70 million for a contingency fund for our overseas response. When you compare $70 million to what we're spending on our counterterrorism efforts, that is pennies on the dollar, right? And I don't mean to be hyperbolic here. I mean, I think this is a real sort of proportionate analysis that we need to do. What is the threat to the United States, and what is the likelihood of that threat happening, and how are we funding it? You know, the one thing, I spent my entire career in the government, and the one thing I always saw was that we were well behind the curve. And for those of you who've been in the government, you know you were using Windows 2010 and 2015. I mean, that's just, and that was brand new, and you were glad to have it, right? But that's kind of how we've done business, right? After 9/11, we realized, oh, we don't have the capabilities in place that we need to respond to this threat. And it wasn't a surprise. People had been writing and speaking about that issue for years, but it took 9/11 to force us to work through the bureaucracy and make the changes that we all knew were needed. So I propose to policymakers today, what if we were a step ahead and not a step behind? What if we took all the evidence that we now have about all the diseases that are emerging around the world and the capability of other countries to stop it, and we said to ourselves, let's fund that now and not wait for the pandemic flu of 2018. That's where I'll leave it.
Hallelujah. Okay, thank you. What an incredible panel. I mean, I think your comments have really put the risks very, yeah, exactly. We're all convinced. But let me ask you some difficult questions. First, okay, U.S. is de facto the first responder. We've seen that in a lot of these outbreaks, but we certainly need our international partners as well. There's lots of coalitions that act in all of this. What is the role of the U.S. versus what should others do? In particular, organizations like the World Health Organization, there have been some reforms. Are they enough? Are we, in terms of our U.S. interest and action in this area, how are we working with the WHO to move forward? And maybe I'll ask Rebecca, and then I'll ask Jeremy to follow up on that.
Sure, thank you for the question. On that, I think it's a little bit what Amy has said in terms of we can't, and as I said, we can't protect our borders being just here in the United States. We have to know what's out there. We have to be able to make sure that countries have met their international health regulation core capacities so that they are able to respond and protect. So it is really important that we have that connection. So the role of the U.S. government in building that capacity, making sure countries have it so that they can respond, they can make sure they can detect at the lowest level, and that they could prevent in the future and mitigate the risk is very critical. So the role of the U.S. government in building that capacity, as you heard from David too, and CDC does this as well in terms of developing diagnostics. With Zika, it was a lot of the diagnostics that came from CDC, that how do we rapidly roll these out? So the importance of being able to have that and keep the science and innovation, build, and I think there's also things that come globally back to the United States, and I think we learn, for for example, with Zika, we are following in Brazil and Colombia pregnant women who are giving birth to children to understand the full spectrum of Zika congenital syndrome. And being able to have that so that we can bring that knowledge back here to the US of how we can protect and detect here as well is important. The role of WHO is a very critical one, and there has been the reform. I think one of the things with the reform, though, still is the funding that was required for it, as both Jeremy and Amy said, is not meeting the level that's needed. So again, they're a little bit handicapped in being able to implement. I mean, there were at least 4 different panels after Ebola that made recommendations, and the ability to implement these recommendations is limited both by the resources, human and financial resources, to do this. WHO plays a very critical role in being able to declare a public health emergency of international concern. They're able to make sure that they can convene, but I think the ability to surge and the coordination, as we talked, is needed in U.S. government, is also needed at the global level in bringing together governments, bringing together MSF, Médecins Sans Frontières, the ability to bring different organizations together and countries is critical, and they play a key role in that. For example, in Ebola, there were many people who wanted to provide PPEs, but again, some countries were packaged one way, and in other countries didn't have the complete package, so you were getting a mix of things. So it's how do we make sure that we're coordinated to make sure that what is a standard PPE kit that goes for healthcare workers is important in these efforts. So WHO is, in my opinion, is not having the necessary resources to meet the needs and what has been put forward in the reform that is required for that. So the role to be able to make sure that we have that global coordination is critical in those efforts.
So a new DG is about to start at the WHO. Jeremy, if you were sitting next to that person, whoever it might be, How can they get this money that's needed? I mean, I agree with you. There's so many postmortem panels on Ebola, okay, but no action to really change things. Limited action.
By resources.
Yes.
By resources.
And certainly from the resource standpoint, no change. What do you say?
Well, so on the WHO piece, that's something I have looked at very closely. One of my extracurricular activities now is serving on the independent oversight panel that WHO created after the Ebola response to supervise and advise on how the post-Ebola emergency reforms are playing out. So I will, in fact, be advising the DG on exactly that question, I and a few others. One of the points that the committee has made is, yes, more resources are clearly needed, but WHO also needs to demonstrate that it has the capacity and the credibility and the accountability to expend those resources wisely. And so it won't do to simply load a lot more money on WHO and hope for the best. And that's not going to fly with any donor. It certainly wouldn't have flown with me when I was on the donor side of the equation. But the donors also can't expect that WHO will be able to fully get its house in order before the money begins to flow. And so there is a bit of a dance that needs to go on here where each side needs to take a leap of faith or a partial leap of faith in order for this to work. And I think what we're seeing on the committee, and our full report on this will be coming out in a few weeks' time with the World Health Assembly at the end of May. What we're seeing on this is we are seeing really encouraging progress out of WHO. I went to Nigeria in early March to visit WHO's emergency response there, and was quite impressed at the progress that had been made. It was dramatically different than the performance we saw from WHO when Tom Frieden and I went out to Liberia in August of 2014. So they're making headway. There is a lot further to go, but I think that they're on a much better course than they were, and sustaining that will require that donors continue to support and expand that support. WHO gets varies, but on average about 10% of the overall emergency response funding in the world that goes towards health. If you compare that to the World Food Program, which gets the vast majority of the funding that goes for food security, or UNICEF, which gets I think the preponderance of the funding that goes for water and sanitation or children's education, that's a comment both on the amount of money that is out there and on donors' traditional perceptions of WHO's ability to spend it wisely. as WHO expands that capacity, I would hope to see donors beginning to recognize that and reinforce it with funding. Two other points I'd make. We don't just need WHO to work at a global level, we need the global emergency response system to work on these issues. And that was a huge, maybe one of the biggest challenges on Ebola, was all of these different players, different UN agencies, NGOs, donors, and the countries themselves, of course, without a clear system for coordinating amongst them. The UN created something called UNMIR, which I think in retrospect, they called it a health-keeping mission based on a peacekeeping mission model. That didn't work very well. And I think everyone, for the most part, recognizes now that's not how we would seek to do it in the future. That doesn't answer the question of how we would seek to do it in the future. And so that needs to be much better defined and articulated. My own sense is that generally, these systems work best when they build on models people already understand. So something similar to the normal UN humanitarian response architecture, tweaked to be more appropriate to a health emergency, is the likeliest to succeed. And then the last piece on that, and kind of to the initial question, Amanda, that you posed, what should the U.S. role be versus others? I think the U.S. government needs to expect that it will be able to fill the breach when other international institutions fail and have the capacity to do so. Obviously, we want those institutions to be strong. We want the UN emergency architecture to be strong. We want the WHO to be strong. We want other donors and other countries to step up effectively. But our security depends as well on us being able to do that. And in the same way that we wouldn't put our military security fully in the hands of international systems, we also have a very strong military ourselves, so that we have that safety blanket. We need, as Amy said, we need a comparable degree of confidence and a comparable mentality around global health security risks, and we need to build our own systems accordingly. That doesn't mean we want to have to do everything, but there's a good chance we may need to have to do quite a bit of it. And I don't see at this point in time that we're investing with that kind of mentality in mind.
Yes, okay, but all of you have mentioned the earmarked funding for response that can show up late, that has to be negotiated on a case-by-case basis. What are the real prospects for changing that kind of dynamic? Amy, do you have some insight on that?
So it's frankly at this moment in time, having insight into what Congress will do when it comes to the budget is, anyone's guess. My hope, though, is that there will be enough players from both sides of the aisle, as I don't think, both the Trump administration as well as the Obama administration had suggested creating a contingency fund. I know there's support on both sides of the aisle for creating that sort of fund. I think the questions that are out there are making sure that the fund is used as it's intended. But I think that's a solvable problem. You could scope it the way that we scope the Stafford Act, for example, which is something we use to respond to natural disasters in the United States, so that there are certain triggers that have to be hit before the money can be used. So look, we're looking to all of you to make your voices heard when it comes to Congress about why this kind of fund is so necessary.
And from an inside the budget process perspective, what's your view?
Well, it's in a public forum, I would say from the DoD's perspective, we clearly intend to continue our level of support, and I'm sensing throughout the government that they see this as a important issue. But of course, the budget will be, it's at OMB right at the moment, and I think it's next week or the week after it will go over to Congress, so we'll have a better view on that, if you will, at that point. But as I've articulated, I think everybody else has, I think it's recognized that this is an important area, and I don't see I'm not seeing storm clouds, at least in DoD, relative to our various efforts in this area.
Okay, and in the context, let's just ask, how scary is the scary avian flu in China? How worried are you?
I think initially it was being able to monitor and to find out about it early was important, and was not so worried, then sort of thought, okay, well, we really do need to think about this, and they're making a vaccine for it now. So as we see the spread and see where it could go and what could happen and how we mitigate that risk, wanting to, as we've all talked about, the importance of being able to prevent that and be able to respond, the value of having those tools ready. And this is why the new vaccine is being developed. So this is important. I wanted to talk a little bit on the budget. So with the Global Health Security Funds, we received, the CDC received $583 million that goes through fiscal year 19. And those funds are to work on strengthening the capacity of countries within all of U.S. government efforts here for this. And so through those efforts, we have been able to move rapidly in doing those efforts, but I think it will, building public health infrastructure is not something that's done overnight. What we heard Jeremy say about Nigeria not having a large Ebola epidemic, being able to stop it with the 19, was because they'd had 10 years of building public health infrastructure in terms of the field epidemiology training program. They had an emergency operations center already established. So having those pieces there that are sustainable does not come overnight. And so the importance of continuing this work to make sure and get countries to put domestic financing into this is really critical going forward.
Yeah. Just a follow-up question on that. I mean, these countries are very poor. They're spending $30 per capita on their healthcare systems. They have many demands that are in their hospitals every single day. Of course, we hope that they'll honor international commitments. Of course, there's interest, but history shows that public health is sort of the last thought when you look at public spending on healthcare in some countries, understandably. What kinds of incentives could be created for greater domestic spending, at least in the middle-income countries in this area? I mean, I know there's the measurement incentive that we have with the joint external evaluation. Is that strong enough, or could there be higher-powered incentives that would be created by U.S. funding, for example?
I think that's a beginning. It gives a place to start, but typically in many countries, ministries of health are not the highest line ministry in the government. And so getting it to the Ministry of Finance and truly understanding the threat, understanding like if you don't have this, what it's going to be, and putting it in economic terms, as I talked about, 65 cents per citizen versus $60 billion a year on this is really, really critical. And being able to put it in the terms of the policymakers that need to understand this is important. And to put it at the level, I think we've all said that health security is national security. It disrupts governments, it disrupts commerce and trade, it shuts borders. So to make sure that can be prevented is important, and bringing those messages forward. Innovative financing is another area, and this, bringing in some of the private sector, some of these discussions is important. Thinking about, for example, there's one innovating cold chain in Zimbabwe where they're using the electricity coming off of cell phone towers and being able to put that into use to have a cold chain to deliver vaccines, to deliver medicines, but it's being paid for, from the taxes off the cell phone, towers. So some of these innovative ways of looking at financing will also be very important.
And I think the other thing that the Global Health Security Agenda has done, because of all the interagency discussion, is having a common voice about that when we are actually interacting with our partners around the world. So that the ministries of defense and the ministries of health are all hearing the importance of the issue. And I'm optimistic it's having an effect.
Yeah, I just want to address the fact that there's been some controversy over putting the public health and security communities kind of into the same room on this issue. I certainly understand the sensitivities to doing so, but having the security communities understand why this is important to a country as a whole, having them know the public health ministers and have those relationships in advance. One, it was hard for us in the US, but having worked on the Global Health Security Agenda, it is not common practice throughout the world, and we want to build that connectivity. And so, while I recognize sort of how it's sometimes uncomfortable to talk about them in the same space, I think it's critical if we want the kind of attention and funding and prioritization that we believe should be placed on these issues.
I'm sorry. I was just going to say, if you think about the response effort in all of these countries, it is typically not after it gets out of the box, if you will, it's not going to be the Ministry of Health. It's the primary lead necessarily. So to your point, it's absolutely essential, and we are preaching to the choir here probably.
Yeah.
And it's another example of the important and unique role of U.S. government leadership. The U.S. has the convening power to pull different parts of those governments together in ways that in some developing countries, those ministries might never otherwise speak to each other if the U.S. were not putting that issue on the table.
Okay, well, let's go to you, the audience. Raise your hand. Please introduce yourself and where you're from. We'll take 3 at a time. So in the back, Bill.
Good morning, Bill Costello, Embassy of Australia. I just 2 observations before my question, if I may. First of all, I led the task force on Ebola in our foreign ministry. A much smaller response, but I can tell you the lessons and the experience was exactly as described for the US, including that bit where early on everybody's looking around the conference table and saying, who's going to step forward here? And my boss did, and that took over my life for 6 months. My second observation on the question of incentives for health financing, I think this is critical, and my suggestion would be when the IMF is raising this in Article 4 missions to developing countries, you'll know you're onto something. So that would be my thought about how you get traction on that one. And my question is, what about animal health, particularly in the US government experience? I mean, the pathogens are coming generally from wildlife to domesticated animals and to us, and I've heard it said that really the animal health industries don't really have the right incentives to really help combat this issue. So I'd just be interested in the experience of the panel on dealing with the animal health industry. Thank you.
Okay, great. In the back.
Morning. Anit Mukherjee from Center for Global Development. I work with Amanda at the Global Health Policy Unit. In my earlier life, I was coordinating the HIV response in India from the Treasury and the Prime Minister's office. So we economists have to give a lot of justification why we are talking to global health persons. So one of the issues that we face, and I'm not sure if there are any other developing country professionals here, are really very different information coming from different parts of the global health community. For example, in 2004, while we were in the middle of planning for the next phase of HIV, we were given figures of between 22 million and 5 million in terms of projections of India's HIV epidemic. Turned out to be 2.5 million, and that was our own data and our own survey. Now, the problem then is that you've mentioned about the Treasury is how do you actually bring one voice and bring a credible data and voice to the discussion, to the table. And these are countries which have their own capacity. And how do you complement that capacity rather than coming in with something which is completely out of the table? Second, and this is I think it's a caution to this Washington discussion, is that if you have a DoD-led response, in many countries you will get pushback because we don't want boots on the ground. So short of DoD going into Liberia and all that, but how about a pandemic coming from India and you have DoD with $10 billion and USAID with 0? How do you manage the domestic optics of the politics than on the response side?
Okay, and a third question over there.
Hi, I'm Stephanie McKay. I'm from HHS. So I'd argue a lot of funding and financing comes from people internalizing a threat, an understanding of a preparedness and a need for that threat. So with terrorism, just understanding a need for preparedness of that, or also natural disasters, like you said, with the Stafford Act. So, and then on the flip side, with climate change, we haven't really internalized that in the United States, don't have a robust preparedness mechanism, and also with infectious disease. So how do we, from a sociological point of view, kind of implement and spread that need for preparedness for infectious disease and pandemics?
Excellent question. Okay, so we have 3 very thought-provoking questions. Do you want to lead off on the Department of Defense issues? who's involved when? I mean, I think you said DoD generally doesn't lead these kinds of responses,
Right.
but it sort of speaks to the importance of having partner agencies adequately staffed and financed too.
Absolutely. Thank you for that. And we're very sensitive to the fact that boots on the ground can be obviously problematic. And when we're actually working with various countries, it's primarily through their militaries and trying to work whatever the needs they have and perceive for the rest of their government. But using us as the example, it's usually OFDA, the Office of Foreign Disaster Assistance, that whenever anything, Ebola was a bit of an exception, but anytime there is a disaster going on or humanitarian response required, they are the lead, and then they will determine, after they've had their boots on the ground, what part of the government would be best to respond to that. And we get involved only when we provide a unique resource that no one else can do, or if it's such a large effort that it is clearly required to have what the military can bring, because we bring, obviously, logistics capability, lift capability, things that aren't necessarily resident or readily buyable, if you will, within our resources. So, and that ends up being about 10 to 15% of the time when the U.S. actually responds to something overseas. So that's the mechanism that we typically use in these kinds of events. And usually, as I mentioned earlier and you reinforced, we're supporting. We're also an expensive player relative to the rest of the government, typically, and it all has to be, we've got arcane rules about reimbursement, et cetera, and so that can also limit what we need. And most importantly, from DoD's perspective, we have other missions, and so we also need to make sure that we can cover all of the reasons why we have the Department of Defense.
I mean, I think the Department of Defense obviously is a big forward planner. I mean, there's that tradition of doing that kind of forward planning, and CDC has done some of those kinds of modeling and simulation exercises, but we could certainly do much more, I think, and learn from how you think about other kinds of threats that emerge in different scenarios.
And I would just, I'm sorry, just pile onto that, but I would say that over the last, and certainly since the Ebola crisis, but it started before that, because remember the Global Health Security Agenda came out before we actually recognized that there was that crisis going on, that there has been much more interagency, at least, and around the world, discussions about these issues. So I see that as very positive. We now know each other. At the beginning of some of these crises, you show up in the room and it's, who are you and where do you work? And clearly the number of crises that Amy talked about, we all know each other fairly well at this point. So, and also I would say we don't expect it to necessarily moderate.
So let me ask you the question, the sort of the political aspects of these competing data sources that Anit mentioned. How do you, and this relates a little bit to the question that was raised about understanding risk and threat, and then I'll ask you, Rebecca, but how do you manage that? How do you know really what's going on given the multiplicity of actors? I mean, we learned about Ebola basically from MSF in the public mind.
Look, we had competing data sources inside the United States. We did not have one understanding of what the trajectory of the disease would look like. And there were many battles about what were the right numbers to use. So I think that underscores the importance of bringing people together. And it goes to this question of sometimes you don't even know who's out there speaking about the data and what information is getting out to the public or to partners. And so bringing people together around the table is absolutely critical. As to the question of what's the data that's resident within the country that's impacted itself, I think that goes to the importance of why, as part of the Global Health Security Agenda, countries are required to put together their own plans for assessing the different parts of the different targets that are in front of them. And I think without that internal assessment, then without the external assessment of the country's own metrics and goals, you can't get to a common understanding. But it's absolutely critical that the country itself is not only a player in the conversation, but is 100% bought into the objectives and to the goals, and that means using the data that they have on hand as well. You test it, you make sure that it's accurate, you sort of look at it from different angles, but you have to have the country at the middle of the solution.
Rebecca, what about this data issue and also this issue of incentives on animal health? How do you work with USDA or others on this issue?
Sure. So just to build off of what Amy said, I think it's really important in terms of measurement, and as you talked about the importance of having data from India, the measurement is really important to be able to achieve your goals. If you don't have that, you won't achieve the goals. So being able to have those systems in place and the importance of coming together. Early on, in many outbreaks, we make sure we're only using one set of numbers because you can see different numbers published, but we say, okay, we're only using one set of numbers. Even if we know that there's new cases reported within 24 hours, if this is the number that's gone out, this is the number we're going to use, that there is that sort of standardization of that during an outbreak. With the modeling of how big the Ebola epidemic could have gotten and the number of deaths, CDC did modeling, WHO did modeling, ours was tenfold greater, and looking at what assumptions go into the model. So it was important then that we sat very closely with WHO and talked about this in planning, because these models were then to be used as how many treatment units you need, how many healthcare workers, how many people involved in burials, logistics, cars. So all of these things have to be put into that context. And so coming together, really looking at those and seeing the importance too of scaling, because you want to be able to be flexible enough to, this is the core we need. And if it grows, we need to be able to surge, scale, and grow it. And that's the importance of having that ability to do that, not have it from the outset, because you may not have the funds or the resources, but you need to be able to figure out how to do that quickly. On the animal health, I would say with USAID, with CDC, with USDA as well, there's been very big, and also I would say OIE has been a very big partner within the global health security on this, is animal health is coming to the table in countries. It's part of the efforts in looking at what Amy talked about, the independent and the internal assessments of the ability. Countries are now determining what diseases or what they're going to be looking for in animals in terms of surveillance, that they're going to monitor regularly. There are now new tests being put in, diagnostic tests being put into countries. For example, Ethiopia has been working on this. And even in Ethiopia, they're trying to look at using drones to deliver rabies vaccine when needed on a quick basis so they can get it out to the rural areas. So there's a lot of efforts of bringing animal health in this, and the importance of being able to do the surveillance and monitoring just as we do with human diseases, and to be able to monitor what may jump into humans, what's the potential for spread, and looking at these areas. And I think across the U.S. Government, as well as with other partners globally and the OIE, that this has been a huge effort.
And Jeremy, let me ask you about another kind of data, which is data on spending. So one thing that has characterized all kinds of emergency responses is a difficulty in knowing what's being bought, for who, where, and how is it being used. That's obviously challenging in an emergency situation. Ebola was maybe a little better, but still no exception. So what do you think about that kind of data? That's really important for a country government too, when so many external actors are in there funding.
Yeah. Well, you'll be really pleased to know that the various inspector generals across the U.S. government are doing, I think, mid-double-digit number of audits and reviews of all the Ebola spending. I think just my office was subject to at least 9 or 10 of them, and probably still a number of those are still underway. So there will be a lot of information coming out. That was mandated as a condition of the money, by the way, that it be scrutinized this way. So there will be a lot of information coming out on that. We did have really big challenges up front budgeting for this, because we really didn't have any good templates to point to of what things were likely to cost. And so most of the response actually came in well under budget, both because I'd like to think we were very responsible with the money, but also because it was very difficult up front to have an accurate idea of how much things were going to cost. And you're also dealing in hypotheticals. You're planning against modeled scenarios. You don't know the limitations of the model very well. And so the budgeting is very, very, very difficult. I think Anita's right on that point, that it's very difficult to know how how big is this going to go, and what are the resource requirements that should therefore be set aside as a part of that? And it gets to a really important point, which is both the value and the limitations of modeling to guide policy.
Yeah.
And this is something I think we didn't do a great job of on Ebola, was understanding the limitations of the models that we had and how that should factor into the policy solutions that we were considering. And so, the models for Ebola were largely built on the types of outbreaks that had happened before. They didn't necessarily tell us a lot of useful information about what was likely to happen once it goes to an urban setting, once it behaves in a different way, once it's encountering different cultural practices than those present. But the models that we had couldn't control for those variables. And so I think that's something we're likely to see again, and that's one of the many issues that's at the crux of the science and the policy and how they interact with each other. And huge difficulties there. One, I want to respond as well to the point on having a DoD versus civilian face on a response. And David's talked about the way we typically approach that on natural disasters. It is really important that it be a civilian face on the response. And for all the reasons that you cited, we had 3,000 troops in Liberia, but we were also, in all the USG messaging, very clear and very explicit that they were not leading the U.S. response. And we were very clear and very explicit that the Liberian government was leading the response in Liberia. And I think it's important, as we have all these conversations, we tend to get very focused on the international response and the international deployments and so on. The people who are every time going to be the ones to defeat and extinguish the disease, the most important players are the national government and the society of that country. And if we lose sight of that, we won't collectively succeed. And so building on national systems, engaging with national populations, and presenting the international intervention in a way that is amenable to the cultural and national context is it's not science, but it's crucial to making the science, it's crucial to making the operations and everything else work.
Well, we're now at the end, so each of you have 30 seconds to sort of recommend to us what we should do next here in civil society, and or to the new administration if you so desire. And we'll do more stuff in the future, so we'll come back. So maybe we'll start with you, Amy.
So I know that at this moment in time, there is a lot of rhetoric coming out of the administration about slashing budgets, and particularly slashing budgets for our foreign assistance. And I think that's a mistake when we're talking about our national security. I think that broadly in terms of U.S. national security, but specifically when it comes to countering the next pandemic, we need to recognize that it's very unlikely that the next pandemic is going to start here in the U.S. It's much more likely it'll start somewhere else and be brought in through some other channel. And so now is not the time to take our eye off of that ball, and that means having the resources to make sure we're as prepared as possible to prevent, detect, and respond to the next outbreak.
Great. Jeremy.
I think the biggest gap we have right now in our planning is we have not planned, we don't know what the policy measures we will need to deploy across a whole range of different diseases. We have a sense of it now in Ebola, but we're not going to face Ebola again in this way. So what happens if a different viral hemorrhagic fever that behaves in a different way explodes in a way we didn't think it could? What happens if a disease that has, like Zika, previously been contained to one part of the world, suddenly starts exploding in another part of the world? What are the diseases that are amenable to behaving in different ways but haven't done so yet? And what do we know about them that will affect how we construct the policy and the operational response? Because the variables of how those different diseases behave lead you to wildly different directions, and we really haven't mapped and charted that out. There's a huge need to do that.
Great. Rebecca.
Thank you. Just to say, we don't know when and where the next outbreak will occur, but we know it will. And we need to continue to make sure that we are prepared, that the world is prepared, and that means countries are prepared as well to be able to detect, prevent, and respond, as we've heard. And the value that the U.S. government plays, both in the role that we do in being able to share our experiences, build the capacity in countries, but then also bring in other important countries and players into this, and the need for that emergency coordination at a global level will be critical going forward.
Wrap us up.
Thank you, and I would reiterate what Rebecca said, that clearly we need your advocacy. We appreciate the Center for Global Development for putting this on, because I think we obviously need to keep the fires burning and promote this and continue all the planning efforts that we have, and hopefully be able to adequately respond to whatever confronts us in an all-hazard sort of approach.
Okay, well, thank you so much to our
Thank
panelists.
you.
Thank you,
Thank you.
audience, for joining us.